Hello, everyone. I am Erin Fuller,
And I'm Marcy Eberts.
and we are clinical educators at the Plaza. And today we are going to review cardiac focused head to toe assessment.
So, a lot of this will be very familiar to you because you've been doing head to toe assessments since nursing school. But when you take care of a cardiac patient, we're going to really specify what matters most in that assessment. So, let's get started with our first impressions, or sometimes we call this the doorway assessment.
The first thing you do whenever you come into a patient's room is you want to start looking around. What do you see? And what do you see that matters? So on this patient here, I see a Foley, I see a rectal tube. Looks like they've got an ambu bag with some oxygen hooked up in the back. They've got a lot of drips going on. They're getting some blood cultures. So this fellow looks like they're not feeling very well.
You can tell a lot from the doorway of any patient. Like, are they looking back at you? Are they interactive? Are they asleep? Do they have one leg over the side rails, plotting their escape?
Are they crouched down at the very bottom of the bed, like their mobility may be impaired? Did they look to you and say good morning whenever you knock to come in?
I mean, there's a part of your neuro assessment already complete.
So that initial encounter when you first come in does make a difference. We want to make sure that you are always introducing yourself. Again, with any patient, you're knocking, giving them the opportunity to invite you in and telling people who you are. Perform hand hygiene.
Of course.
Make sure that you verbalize that you're going to be performing an assessment. And it's nice to kind of walk your patient through what you're finding and what you're doing too.
Always try and maintain privacy by pulling the curtain or shutting the door. It even helps to sometimes say, I'm going to help maintain your privacy by closing this curtain. And then it just makes us look better and helps our HCAP scores also if you make that little announcement about why you're pulling the curtain.
Absolutely. All right, so the first thing you do on any assessment, regardless of the system, is you're going to look at color. So the first thing I do from the door even is I can kind of see what my patient's doing around their mouth, their lips, their tongue. You can see the picture in the top right-hand corner. She has a very, very blue tongue. Her lips are blue. We know that her color does not look right.
Sometimes we have been conditioned to look at pink, warm, and dry in our assessments, but when we look at patients who have brown or black skin, it's important to really look at mucous membranes, tongue in this picture, but looking at the palms of the hands and other places where you can get a good assessment of color.
Next, we're going to look at movement. Like we said before, is your patient going to crawl out of bed? Are they crunched to the very bottom of the bed where they cannot get themselves repositioned and they just look so uncomfortable? We know their movement and their musculoskeletal system may be impaired.
And then lastly, just on our quick assessment is sensation. Are they able to feel you touching them? And do they complain of any numbness or tingling? Just an overall sensation assessment.
All right, now into the good stuff. First, let's start at the top, head and neck. We always want to look at that mentation first. Like we said, it starts at the doorway. Whenever you knock on the door, did they invite you in? Did they say good morning? Did they just mumble and grumble at you, or did they say nothing? We want to make sure that we're checking their orientation, and has their orientation changed? If yesterday you had this patient and they were able to say good morning and hello, it's Tuesday, and today they really don't know where they are, we may have a problem with our perfusion.
Looking at at the face, the lips, tongue, oral mucosa. Oh, this girl needs more than chapstick. I'm telling you, she needs a little fluid and maybe some oxygen because she's looking a little bluish and so dry.
Here's another example of a non-white person who looks like very blue in the lips. We definitely want to be doing an O2 sat on this patient here.
You can assess fluid status sometimes by really looking at the mucous membranes, look at that dry tongue. Just a good way of looking at our overall assessment with fluid.
Now we want to take a look at the eyes. This patient has got some major fluid shift issues here. Look at all that edema around the eyes. That looks so painful. So that's a big indicator that we have a fluid shift problem.
Oh, here's my favorite, is really looking at the neck. Jugular venous distension is not something that you need to assess on every patient, but on your cardiac patients, you need to stop and take a look. So lay your patient down flat, and you should probably see some jugular venous distension because that's normal in everyone. But then as you raise the head up to around 45 degrees, see if that jugular vein went flat. It should. In a normal, healthy person, the jugular vein should flatten with the head of bed raised. But if your patient is still having a lot of distension of that jugular vein, then this is a problem with fluid balance. And in our patients, it's a problem with their heart pumping function. Your heart's not able to pump the fluid out, then it backs up. And where does it back up? Right up here to the jugular vein.
All right, we're moving to the upper extremities. We always want to start with that CMS again. We're going to look at color, movement, and sensation. So our patients, again, able to pull themselves up in bed, wave hello, any of those things. We start with all of our systems. First thing we're going to look at edema, look at their hands. This is a very unilateral edema. So we're thinking here clots, lymphedema, what's going on with this actual
IV
extremity
infiltrated,
oh
maybe.
Gosh, that's a great one.
Maybe.
Yeah.
Mm-hmm.
We're going to look at the coloration of the patient.
Oh, this poor lady. Look, she's so old and her fingers are so blue. Oh man. So looking at that color.
And this is not new, most likely on this patient. She probably has had a perfusion issue for quite a while to have little fingers that blue. So sad.
She has really poor cap refill, I'm betting, but checking cap refill, just a quick little pinch of the fingernail so you can assess how fast it returns, less than 3 seconds for sure, is a better sign.
Temperature, you know those little blue fingers are so cold.
Oh, yes.
The coldest fingers around. And so that's really going to show that, again, we have trouble with our
like perfusion,
perfusion and everything
right?
with that.
Okay.
All right, finger clubbing. Finger clubbing takes time to develop, and it has to do with your cardiac status.
So that last picture was like super obvious clubbing, but this one is a little more subtle. So if you have everybody do it, put your fingers together like this and see if the tips of your fingernails touch. If both the knuckles and the tips of your fingernails touch, then you're all right. But notice on this patient that the clubbing of the nail results in the tips of her fingernails not able to touch. So that is some clubbing.
That's a chronic low oxygen issue.
So always check your radial pulses, and anytime you check any pulses, we're checking them bilaterally, feeling them on each arm. And then if you're not like super sure that you can feel them, a good way to correlate with the heart is to, like, as you're listening to the heart tones, you're feeling the pulse, and then you're really able to like feel a good pulse and correlate it with the heartbeat.
Make sure you're not feeling your own pulse through them. All right, let's take a look at the chest. I mean, as soon as you walk in, you're going to start seeing if you see that chest rise, right? You're going to make sure that you're looking to make sure that they're having breaths coming through that gown.
Right.
But you also are going to look at the actual skin. This is a pretty exaggerated example here, but this is the pectoralis.
Excavatum.
Like the Harry Potter. So you also can see a previous cervical wound here. So we're looking for skin colorization, everything like that, asymmetry, scarring, all of those things on the chest. We will be listening to heart sounds. We're going to go over that in a minute. You'll be assessing your rhythm, be listening to lung sounds while you're in the chest, and then always assessing for chest pain.
When you're asking about chest pain, getting some quality descriptors from the patient of their chest pain can really help us lead towards what's causing it. So like, for instance, a pressure or squeezing of the chest is more likely to be angina, where maybe a ripping, tearing is more likely to be an aneurysm. So just letting them describe the pain is really helpful.
Then we'll also be assessing our breath sounds. All right, let's talk a little bit about heart sounds.
Oh, the old lub-dub.
The old lub-dub. So as you can see in this picture here, the lub is the start of systole, and the dub is the start of diastole.
It really helps if you take a second and think about which valves are open during which heart sound and which valves are closed during each heart sound. So the sound of the lub, the S1, is made by the closing of the mitral and tricuspid valves. So when those valves close, that's your lub. That's during systole when your aortic and pulmonic valves are open. And then the dub, or the second heart sound, is made when those aortic and pulmonic valves close during diastole.
Like Marcy said, it's so important to know that because it helps us identify if there's problems and where those problems can originate from. Let's listen to a normal heart sound.
Very good. So when you're thinking about those normal heart sounds, valves opening and closing, now let's correlate that back to the electrical part of the heart.
So make sure that we are knowing how to do our rhythm interpretation. Any patient that is on a polymonitor, we got to remember that we're going to do that rhythm interpretation and print strip out every shift. And make sure that if you are a newer nurse, that you have taken that what do we call that? Rhythm interpretation class prior to doing this on your own. So there's a couple key things, basic steps to do our rhythm interpretation. First is it regular, irregular? That's the first thing we want to start looking at. You can see this top one has pretty QRS, a nice P wave to go with each beat. And we missed something in that bottom strip.
Yep. Regular or irregular is where you start, and the next is the heart rate. So lucky for us, our monitors will tell us the heart rate, and it's right most of the time. But if you had a strip and you wanted to double check it, printing off a 6-second strip and counting how many QRSs in that strip, then multiply by 10, and you've got a pretty good idea what your heart rate is.
Yeah, so the strip here is a rate of about 70. And next, we want to check and see if we have a P wave for every QRS complex. You can see the top one, we have very pretty P waves, and the bottom one, we have no P waves. So that's a really basic way to get your rhythm interpretation quickly.
All right, let's go on to listening to our heart. And when you listen, there is a systematic way you should be listening. And for our cardiac patients, it's really important that you don't do just a cursory one stop fits all kind of, I'm going to listen in the center of the chest and call it good. No, let's really be more professional about these, a little more clinically astute about listening to heart sounds. So we're going to listen over each heart valve, the aortic, the pulmonic. We listen to Erb's point, then the tricuspid and the mitral valve. So as you're moving through your heart, your valve locations, you're starting there in the second intercostal space, right to the right of the sternal border. That's really listening to the aortic valve the loudest. And then you're moving over on the other side of the sternum where you're listening to the pulmonic valve. Then scooch down just a wee bit and you're listening to the Erb's point. Erb's point is just a magnification of any murmurs that you might have heard. And then tricuspid valve is moving down to the fifth intercostal space, still right at that left sternal border. And then you can move laterally to about the midclavicular line where you're listening for the mitral valve.
And that actually is the apex of the heart. And in that apex area is the best place to actually listen just to get your rate, because it's going to be one of the loudest spots you can get. So down here in that
apical pulse, yeah, right? So a good way to remember this, that I always think about this when I'm listening, is all pets eat too much.
Oh, cubs.
Is it just my pets?
No, all pets.
All pets eat too much. So just listening to the aortic, pulmonic, Erb's point, tricuspid, and mitral.
And as Marcy mentioned, Erb's point is a great spot to listen for a murmur. We never expect you to diagnose a new murmur or to really even be able to determine what type of murmur it is, but it is important to know if the patient has a known murmur or if you're hearing something new. It can be a little tricky to hear those, so we've got some examples coming up next. This slide really shows different areas and the type of abnormalities you might hear in each of those areas. Whenever you listen, if you hear something new, the important thing is to notice whether you hear it louder during S1 or S2, and that'll kind of give you an indication of where it's happening at. All right.
So these videos are from the Khan Academy, which has some great YouTube videos if you're interested in more learning more about heart murmurs.
All right, here we go. Let's take a listen. All right, so that's an example of all those different types of murmurs. Again, you're not expected to diagnose these, but know if they have a murmur, you should be able to hear it, or if something is new.
I can tell you from experience that finding a new heart murmur in a patient who's going down the tubes is super satisfying.
All right, let's take a look at the lungs.
Or listen.
Or
So when you're taking a listen to the lungs, you should really listen anteriorly and posteriorly. And you're listening as you go down to each quadrant. Sometimes it's hard when a patient's in bed. So they're like laying in bed. How are you really getting a good lung assessment? It's just really important that you listen to their back and their front. I mean, it's easy to listen here, but you're going to miss a lot of pulmonary edema if this is the only place you listen. So have a friend help you, pull them up to listen, or roll them on their side and listen as they breathe through each of the lobes of the lungs.
That's a great time to do a skin check too. So roll them to the side as you're listening, and then take a look at their backs and their bottoms while they're rolled over. All right, let's listen to some lung sounds. Oof.
You telling me that one poor guy has stridor, asthma, pulmonary edema? Oh my.
And did you see he had CF too?
Oh man.
Fibrosis.
Yeah, it's bad. But just a quick review of those breath sounds that you might hear. Just remember, you hear stridor. That's more of an upper airway problem where the coarse crackles or might be more of the lower airways.
And we're thinking about fluid overload during those crackles and things like that. And so you're looking then at their cardiopulmonary status and what may be going on.
All right, let's move down to the abdomen on our cardiac assessment. What are some things we might be especially looking for on our abdominal assessment? He's not pregnant.
Distension or pregnancy, we're not sure here.
No, it's a dude. Look at his hairy arms and his hairy belly.
We've got some problems here.
Whew, you can have a distended abdomen for lots of reasons, but heart failure is for sure one of them, because if your heart is not pumping very well, then your blood can back up into the liver and lead to that hepatomegaly that can cause a really distended, firm abdomen.
Like this man. He needs some fluid taken off probably. Next, I want to look for edema in the abdomen. This is a very good example of cellulitis in the abdomen, red, pitting in the abdomen, dry skin. There's something going on here.
What do you think his respiratory assessment was like?
I'm gonna guess not good.
I'm guessing this is not his only problem.
Yeah, probably not.
Great picture.
Gotta check those bell sounds.
Make sure that those bells are moving round and round. So just a quick listen for that gurgling in all four quadrants. I suppose.
So they say.
So they say. All right, let's move on to lower extremities because we can get some good cardiac clues from the legs and feet.
All right, we're looking for edema again, just like we did in the upper extremities. Again, make sure that you're looking for bilateral or unilateral in both of the feet, both of the legs to make sure that it's all the same. This is the same. This is some pretty significant sitting edema in the bilateral
You
lower
should
leg.
not have a memory foam mattress on your tibial,
No.
your frontal tibial.
We'll leave those for the mattress.
Yeah, okay.
Wounds and ulcers. I mean, this is a classic example of a venous stasis ulcer.
I need gloves on just to look at this picture.
Yeah, there is a perfusion and a blood flow issue to this leg.
Yep.
We have a problem.
Veins, should be flat and against the legs. So varicose veins are common. I mean, a lot of y'all nurses probably have some because, we're on our feet a lot.
Yeah, it has to do with the valve not working. You got a leaky valve in the leg there.
Hair distribution. This one's kind of interesting. When you see a dude with bald legs or just the front of his shins are bald, have you ever wondered what that means?
It has to do with their respiratory status typically. If they've got poor perfusion, then oftentimes they'll have areas of hair loss in the front of their legs.
So their circulatory status and their blood flow to their legs. If they have less blood flow, they might have some bald patches on the front of their tibias. Homan sign, flex that foot up and have pain, and that could be a sign of a DVT.
Look at that red leg.
Dude.
There's a problem there.
Looking at this, that color difference is really important to look at. Is that leg going to be, is it cold and pale, or is it warm and edematous and red? That's the difference between an arterial occlusion and a venous occlusion.
Next, on those toes, do the fingers. Then you really do need to hear your pulses in your lower extremities as well. Just like Marcy said, for the radial pulse, if you're having trouble feeling your pulses in your lower extremities, do it while you're listening. See if you can. I know that's kind of a long reach, a little stretch, but you may
feel a radial pulse while you feel the pedal pulses, so you can feel them both. When we talk about our heart patients having multiple vascular issues, oftentimes, so often that the plumbing in the heart is part of the whole house, but the plumbing in the feet may be bad too, or the plumbing in the legs. So really correlating in your cardiac assessment any peripheral vascular problems.
That wraps it up. There's some key things to look for when doing your head-to-toe assessment in your cardiac patient. Biggest thing, remember, make sure you're looking for things that have changed. But that's all we've got. We hope you enjoyed.